Welcome to CME on ReachMD. This episode is part of our Minute CE curriculum. Prior to beginning the activity, please be sure to review the faculty and commercial support disclosure statements, as well as the learning objectives.
Hello, this is CME on ReachMD, and I'm Dr. Emilie Vander. Here with me today is Dr. Karin Blakemore. Dr. Blakemore, let's focus on FNAIT. Why is it often considered the platelet equivalent of Rh disease?
Well, it's considered the platelet equivalent because in many ways it is. It's that the platelet antigens present on their surface, and the mother may recognize them as foreign if there is no counter antigen that she has. So she may form an antibody to that platelet antigen the same way that this occurs in red cell alloimmunization. Where the red cells are presenting their antigens. And if she doesn't have that antigen, she may see that as foreign and form an antibody. And that antibody is IgG. And as we know, IgG crosses the placenta. And when it crosses the placenta into the fetal circulation, it can, in the case of FNAIT, destroy the fetal platelets. And destruction of the fetal platelets is going to lead to the possibility of some severe sequelae, such as bleeding. The most severe sequelae is going to be a head bleed, intracranial hemorrhage. There are a lot of platelet antigens on the surface of platelets, and there are actually at least 41 of them, but there are some main antigens that cause FNAIT. And they're all numbered. There's HPA 1A, 1B, HPA 2A, 2B, HPA 3A, 3B, and they go on from there. The one that is probably the most commonly associated with FNAIT, not just in Caucasians, but in other populations, is anti-HPA 1A, where the mother doesn't have that antigen. The mother is HPA 1B, 1B. African Americans, we may see more commonly an antibody that a mother may form to HPA 2 or HPA 5, whereas in Asians, you may see an antibody that is formed by the mother to the system that's HPA 4 or 5. So this is something that unfortunately cannot be detected usually with any reliability as far as what fetus is going to be at risk before the first baby's born to that couple where there's been an incompatibility of the platelet alloantigens. If the father has the gene, he may pass it on, and thereby a homozygous mother for the opposite of the offending antigen, as I like to call it, the offending antigen being the fetus's and father's antigen, then she may form an antibody. That antibody will cross. That antibody can cause platelet destruction in the baby and thrombocytopenia.
Thank you, Dr. Blakemore. I always find it fascinating how much variation there is in different populations. I know there's a lot more work to be done to understand these different platelet antigen genotypes within multi-ethnic populations. So I know there's more research to be done on this in this area. I also think it's probably important to note that some of these platelet antigen subtypes are associated with more severe forms or are more commonly seen than others. I think, as you mentioned, HPA 1A is one of the most common platelet antigen subtypes associated with this disorder, at least in Caucasian populations. But definitely, interesting to know how vast and varied these antigens are.
Right, and only 2% of us will be HPA 1A negative. And the mother will be HP1B on her genotype. But not all couples where the mother is HPA 1A negative are going to have a baby, even if the father has the antigen and passes it on to the fetus. Not all couples are going to experience FNAIT.
Well, I think this has been our time. Thank you for listening. We hope this discussion will be helpful in your clinical practice.
You have been listening to CME on ReachMD. This activity is provided by Omnia Education and is part of our Minute CE curriculum. To receive your free CME credit or to download this activity, go to reachmd.com/CME. Thank you for listening.